Then selamat sejahtera and a very good evening to all the participants who have taken the time to attend episode 5 of our Let's Talk About series by the Malaysian Medical Association's Women's Health Committee. To tell you a bit, again, thank you so much for starting off with the hearts. That's one of the specialities of the webinar with the Women's Health Committee webinar series, where our participants every week without fail are very emotive. They engage with us by putting up these emojis. You don't need to just do that. The Q&A, housekeeping announcements, the Q&A question and answer box is open. Once you start listening and you have questions, we are happy to take all your questions. It's about raising awareness through education. We are at episode 5. This episode, I've got to thank MMA Kedah branch for collaborating with us. In particular, Dr. Sridharan Rao, who is the vice chair of MMA Kedah, for allowing us this platform and collaborating with the Women's Health Committee. Thank you, Dr. Sri. Thank you, MMA Kedah. And again, another shout out to 3 dynamic women who make up the rest of MMA Women's Health Committee. They are Dr. Vani, who is a primary healthcare provider in KL, and Dr. Juliet Matthew, who is attached with IMU. And then at the secretariat, we have Miss Mutu. And last but not least, all you wonderful people who have tuned in today to listen to us. Without further ado, episode 5 is about saving mothers' lives. How can we work as a team to make an impact, right? And to deliver this very important topic, we have an extremely distinguished speaker with us tonight. And I believe it's a full circle moment. Let me introduce him. It's none other than a good friend, Dr. Muniswaran Ganesan, who is the president of the Obstetric and Gynecological Society of Malaysia, which is the OGSM. He is also the founding president of the Malaysian Obstetric Medicine Society, aptly named MOMS, Malaysian Obstetric Medicine Society. Dr. Muniswaran is trained as a subspecialist in maternal fetal medicine with a passion for maternal medicine. Obviously, his name starts with M, so he has taken maternal medicine. He pioneered, leads, and advocates maternal medicine services with a passion, okay, and which he established upon his return from UK in 2016. He runs a comprehensive one-stop high-risk pregnancy clinic at Pantai Hospital, Kuala Lumpur, and is the resident obstetrician for complex cardiac diseases among pregnant mothers at IJN, National Heart Institute, right? His passion for teaching is evident as he still dedicates his time teaching postgraduate trainees at University Malaya and MRCOG trainees in the parallel pathway, apart from being part of the committee responsible for the national ONG curriculum. Apart from receiving his fellowship from the Royal College of Obs and Gynae, he completed his subspecialty training in maternal medicine in the UK. And if that wasn't enough, he went on to obtain his master's in ONG from University Malaya with a gold medal, and also completed his master's of law in healthcare and medical law. He is also a member of the Academy of Medicine of Malaysia. We have come a full circle moment because, unknown to you all, the reason we have the Women's Health Committee, which was started in 2022, was because Dr. Muniz came up with this idea. Siva, MMA has got 26 committees. Why isn't there one related to women's health? And as they say, the rest is history. And here we are today, 2 to 3 years later. Apart from an active clinical practice, he's very much involved in academic pursuits as well, and has been the speaker and the scientific chair for various national and international conferences since 2015, especially with regards to maternal medicine, high-risk pregnancies, and obstetric emergencies, which remains his passion. He has authored numerous books and book chapters, including the award-winning Handbook in Obstetric Emergencies and Preeclampsia, an Enigma. He remains dedicated to his passion, which is to establish maternal medicine services in Malaysia and to improve the standards and quality of care for mothers with medical complications in pregnancy while aspiring obstetricians. Without further ado, can we welcome Dr. Muneeswaran Ganesan to take us through today's topic, very important, saving mothers' lives. How can we work as a team to make an impact? Dr. Muniz, the floor is yours.
Thank you so much for the very kind introduction, Dr. Sivabala. And it's always a passion to speak at this wonderful webinar. And I'd like to sincerely thank the MMA Women's Health Committee. You have done a wonderful job leading this committee. And I'd also like to thank MMA Kedah branch for giving me this opportunity. Ladies and gentlemen, to tune in at 8 p.m., a day after having that very important historical march to Putrajaya, my heart is with all of y'all who took that wonderful march. Thank you for joining in today. Saving Mother's Life. How can we work as a team to make an impact? Ladies and gentlemen, I'd like to declare that I've got no conflict of interest for this talk. It's purely an academic talk based on passion. Now, what is the essence of my talk? I believe this quote is extremely important. We can't have healthy societies if we do not have healthy mothers. And that's going to be the mantra for the day and for the talk in the next 40 minutes. Now, what is the importance of this talk, ladies and gentlemen? Globally, maternal mortality is on the rise. If you think it is going down, it is not actually going down. Importantly, deaths are related to social inequalities. Where certain parts of the world, women do not die, but certain women remain vulnerable. And more importantly, mothers are dying from non-obstetric causes, especially in developed countries. And that remains the problem of the day. Let's take a look at the lifetime risk of a mother dying during childbirth. If you are from a high-income country, be it the UK or the US, the chances of dying is almost 1 in 8,000. But if the same mother with the same age and the same risk delivers in another country, a low-income country, the chances of dying is way higher, 1 in 66. So this is a significant global inequality where it does not depend on your risk, it depends on the quality of care that one receives. Let's take a look at some important facts with regards to MMR. Globally, MMR has reduced by 40%. But by the time I finish this talk, there'll be 2 mothers who would have died every 2 minutes. In the next 60 minutes, there would have been 120 mothers who would have died globally. Now, importantly, 700 deaths could have been prevented by good care every day. And 90% of these deaths occur in low and middle income country, not in Malaysia, but in low middle income country. Now, importantly, out of these 90% of deaths, 70% are in the sub-Saharan Africa. But 1 in 5, 17% of total maternal deaths happen in the region where we live, Southeast Asia. And of course, the statistics are higher in conflicting areas, fragile areas, areas at war. Fortunate that it is not in our shores. Let's take a look globally, ladies and gentlemen. The leading cause of maternal death throughout the world remains PPH, followed by indirect causes, which are medical disorders in pregnancy, followed by hypertension and illegal abortion, all of which I believe we can make a difference, especially in the primary healthcare. Let's take a look at the UK report. 275 mothers died in the triennium of 2020 to 2022. If you take a look at the trend, the incidence of mothers who died in 2022 was similar to the incidence of mothers who died 20 years ago. It went down, it came up. So maternal mortality rates are on the rise in the UK. If you take a look at the leading cause of maternal death, it is thrombosis. Venous thromboembolism is the leading cause, followed by COVID-19, cardiac diseases, and mental health. A significant amount of mothers die from suicide after childbirth. That is the fourth leading cause of maternal death. And then comes infection. Now, what is important about UK, they don't just follow up mothers for the first 6 weeks after childbirth, they extend the data for a year after childbirth, and then comes suicide, then comes malignancy, then comes cardiac diseases. In Malaysia, we only follow up maternal deaths up to 6 weeks. If only we extended to a longer period, I believe mental health will be the leading cause of maternal deaths a year after childbirth. Now, what is important in the UK report? We spoke about inequalities. If you're Asian, the chances of dying is 2 times higher. If you live in certain deprived areas, the chances of dying is 2 times higher. If you're older, the chances of dying is 3 times higher. If you're overweight, your chances of dying is higher. So there's a significant social inequality among mothers who died. And this is also the true in Malaysia. It depends on where you live. It depends whether you're a Malaysian or a non-Malaysian. It also depends whether you're an illegal immigrant, where your chances of dying significantly changes. If you think that is only true in the UK, it is a similar story in the US as well. Although globally maternal mortality rates have reduced, in the US, the rates are on the high. If you take a look at overall maternal mortality rates, it's 23.8 per 100,000 live births, almost similar to the rates in Malaysia. It was only 17.4 6 years ago. If you have certain ethnicity, the chances of dying is higher. The rates of dying in UK also is ethnicity dependent. It all depends whether if you're a white, you're an Asian, you're black, or you're Hispanic. Let's come to our shores, ladies and gentlemen. We have been very proud of our maternal mortality rates. We are proud that our current figures for the most recent triennium is 24. Maternal mortality rate in Malaysia tripled threefold because of COVID-19. It went up to 68.2, but the most recent level is 24. We have done a tremendous work. But ladies and gentlemen, I think what is important, the rates have plateaued in the last 25 years. Every year, almost 250 to 300 mothers still die because of complications of childbirth in Malaysia, which I believe we can make a difference. And that is going to be the gist of the talk today. Let's take a look at the cause. We spoke globally that hemorrhage was the leading cause. And yes, ladies and gentlemen, postpartum hemorrhage is the second leading cause of maternal deaths in Malaysia. What is the leading cause? It is medical disorders in pregnancy and cardiac diseases rates high. That is followed by hypertensive disorders. That is followed by pulmonary embolism. But I would like to bring your attention to 2009 to 2011. The leading cause of maternal death was H1N1. If only we spoke about vaccinations among pregnant mothers, we could have saved numerous mothers almost 14 years ago. So ladies and gentlemen, if you're going to have one important intervention, it's going to be vaccines. I'm going to speak about the influenza vaccination. Let's talk about cardiac diseases. If we think it's going to be complex diseases, is it infective endocarditis? Is it valvular heart diseases? Is it pulmonary hypertension? The answer is no, ladies and gentlemen. The leading cause of cardiac diseases among pregnant mothers in Malaysia is cardiomyopathy. Not peripartum cardiomyopathy, but it's because of metabolic diseases, which is on the rise. We are seeing mothers who are more obese. We are seeing mothers who are hypertensive, who are diabetic. So cardiomyopathy. The next time you see a pregnant mother who complains of shortness of breath, think of a cardiac cause. Never assume it is normal in pregnancy. So what are the key points from the Malaysian CMD? I think the level has plateaued in the last 25 years. More importantly, if you take a look at the timing of maternal deaths, 1 in 2 mothers died after childbirth. And that's going to be the most important trimester called the fourth trimester, the concept that I'm going to introduce today, where I think we can all play an important role. The next time a mother dies, please don't say it is because of a VTE. Autopsy is essential. Look for a cause. We may look for a solution. Cardiac diseases, especially cardiomyopathy, is on the rise. Mothers in Malaysia still die of infection. Ladies and gentlemen, it is not H1N1, it is not influenza, it is not COVID-19, but tuberculosis was a significant cause of maternal death in Malaysia. And I believe VTE deaths came down because of a wonderful VTE guidelines where we risk stratify and give all pregnant mothers thromboprophylaxis. And other causes includes ectopic, anesthetic complications, suicide, which is importantly significantly high. Let's talk about infections. So this was a study we did in 2018. We looked at mothers who died from postpartum sepsis. We looked for a cause. Was it H1N1? Was it dengue? No, ladies and gentlemen. The leading cause of infective cause among mothers in Malaysia was tuberculosis. We take a look at all the mothers who died from infection. We wanted to identify what was the organism, and to our surprise, it was Mycobacterium tuberculosis. Ladies and gentlemen, tuberculosis is on the rise. Tuberculosis is a leading cause of maternal death, and I think we should think of tuberculosis if we think of a mother who has got an infection, namely because it's a multi-drug resistant TB, and that is why it is important to think, screen, and also treat latent tuberculosis. So TB is a leading cause of maternal death in Malaysia. The next time a mother coughs, don't just prescribe antibiotics. Chronic cough should be investigated. It is okay to do a chest x-ray in pregnant mother. Think of tuberculosis. Now, what are the other causes of maternal deaths? COVID-19 can be prevented with vaccination. I spoke about shortness of breath and cardiac diseases. Think of heart failure. We are now in the business of universally screening for depression and anxiety, where every single pregnant mother, every contact, antenatally, postpartum, screen for depression and anxiety. If you see a pregnant mother who has got fever, think sepsis, screen using lactate. And we also need to think of neurological causes, especially epilepsy, where the incidence of death is on the rise postpartum. Other causes which are extremely unique to Malaysia, there's a high incidence of mothers who died from motor vehicle accidents. So the next time you see a pregnant mother who's riding a motorbike, the next time you see a pregnant mother who comes to the clinic with a motorbike, talk to her. The number of deaths from a motor vehicle accident, although it is considered to be 42 years, is on the rise. We also had a lot of deaths from detention centers. Vulnerable women who are pregnant who were detained had poor antenatal care. If you're an illegal immigrant and you die in Malaysia, your death is never counted for. We have got a lot of deaths from illegal immigrants who are not included in the statistics, which I think should be a point that we should seriously look at. A lot of mothers who had illegal abortions ended up having a maternal death. And more importantly, with a lot of mothers who died from hyperemesis gravidarum purely because of venous thromboembolism. Interestingly, although the deaths have plateaued, if you take a look at the number of deaths that is preventable, almost 80% of these deaths, we believe, could have been prevented with good quality in antenatal care. Let's take a look at the trends again, ladies and gentlemen. I just shared these slides moments ago, and the maternal mortality rate has plateaued. If you take a look at the live birth rates in Malaysia, it was almost 5 in 1970. And the current live birth rate in Malaysia is 1.6. So the live birth rates have reduced in Malaysia. If you take a look at the crude birth rate, the crude birth rate has reduced in par with the reduction in the live birth rate. If you take a look at the mean age of mothers in Malaysia, mothers were younger 14 years ago as compared to now. Although the current mean age of pregnancy in the first pregnancy is 27, I believe it will further shift to the right and it will be above 30. So although the crude birth rate came down, the live birth rate came down, the fertility rate came down, why didn't the maternal mortality rate come down? And that is something that we have to address. So we should not be proud with our numbers. We should work harder and strive together. Often, for many years in Malaysia, we've been talking about adolescent mothers. Let's take a look at mothers who died, ladies and gentlemen. Mothers who died, if they were aged above 40, the incidence of dying is 2 times higher than an adolescent mother. So we should shift our focus from mother who was an adolescent. Of course, we don't want her to be pregnant, but the focus actually should be the mother who is of mature of age, especially the age above 40 should be a concern. She needs better care. She needs good care. She needs to be referred early. Ladies and gentlemen, NCD, I'm sure everyone in the primary healthcare can appreciate that the incidence in diabetes in Malaysia has doubled in the last 10 years. Women in the reproductive age group, up to 1 in 3 may have an undiagnosed diabetes. Up to 1 in 10 may have a mental health. Up to 1 in 10 may have an underlying medical diseases, and hypertension is on the rise. The incidence of obesity among women is also on the rise. In fact, the incidence of obesity among pregnant mothers, almost 1 in 3 mothers who are pregnant were noted to be obese. There's going to be one thing that we beat our Singapore neighbors is that we are leading in the chart of obesity in Malaysia. We do have a significant amount of mothers who are obese embarking on the pregnancy. And that is why we need to modify our care towards these mothers. Postpartum deaths, ladies and gentlemen, I spoke about postpartum deaths. 1 in 2 mothers actually died postpartum. It was not soon after birth, but these mothers were discharged well, who need to be brought in dead at week 2 or week 3, not in the first 10 days of childbirth. So how can we now make a difference? We've appreciated that the maternal death is on the rise. It's on the rise in the UK, in the US, in Malaysia. How can we now work together and make a difference? What can we do in primary care? I believe primary care is the gatekeeper and the solution to solve the pendulum, to solve the stigma related to maternal deaths. I believe these are the concepts. We need to invest in pre-pregnancy care. I'm going to speak about the principles in pre-conception health. Antenatal care has to be modified, not generic. If you're obese, if you're age above 40, if you've got a medical disorder, you need to be risk stratified and escalated, not a generic antenatal care. Only 5 to 10% of mothers had an intrapartum death. So intrapartum care, I think it is of good quality. But ladies and gentlemen, 1 in 2 mothers died in the postpartum period. I'm going to highlight the importance of the 4th trimester. People now believe it is not just the first 3 trimesters that is important, but what happens to the mother in weeks after childbirth, known as the 4th trimester, is extremely important for maternal health. Now, I'm going to introduce the concept of inter-pregnancy care in the primary healthcare, and finally, the concept of transgenerational health. Let's talk about primary healthcare. How can we make a difference? Ladies and gentlemen, every single primary care, every woman in the reproductive age group discussed pre-conception care, not just for the mother, but also for the partner. Talk about safe medications in the reproductive age group. If any mother who is on carbimazole above 15 milligrams, you should be on contraception. It is not recommended or preferred for women in the reproductive age group. Any mother who's on sodium valproate doses above 400 milligrams BD should be on contraception. There should be no mother embarking on a pregnancy on sodium valproate. There should be no father who's going to father a child having taken sodium valproate. So these medications are important. Know the safety of medications among women in the reproductive age group. The next time we see a patient in the primary healthcare, talk to her about reproductive health, contraception, prevention of sexually transmitted diseases, how to plan a pregnancy. And one important concept is to make sure that the mother is up to date with the vaccines. So what are the pearls of pre-pregnancy care for any mother in the reproductive age group? Screen for diabetes. Incidence is 1 in 4. Screen for thyroid, screen for autoimmune, screen for anemia. 1 in 30 couples in Malaysia are thalassaemic. Do a hemoglobinopathy check. You'll be saving more lives. The ideal aim is to embark on a pregnancy at a BMI of below 28.5. Speak about healthy weight, not before pregnancy, but healthy weight throughout a life. Include paternal health, the weight of the father, the age of the father, the health of the father actually affects the pregnancy. The father should be as healthy as possible. Screen about infections, sexually transmitted diseases. Mothers having syphilis is on the rise. So think beyond HIV. It should be syphilis, hepatitis B, hepatitis C, and also think of tuberculosis. Vaccinations is key to save more lives. What supplements do you need? Not every mother needs 5 milligrams of folic acid. Ladies and gentlemen, only selected group of mothers needs high dose. Most mothers only need 0.4 milligrams of folic acid and include vitamin D. Talk to her, educate her, empower her, have a plan. If you think she's high risk, escalate her to a maternal medicine specialist who will be able to refine and modify her care. So how much is folic acid is evidence-based, ladies and gentlemen? Almost all pregnant mothers, 3 months prior to conception and up to 12 weeks of pregnancy, not throughout the pregnancy, but up to 12 weeks, only needs 0.4 milligrams of folic acid. So who needs higher doses of folic acid? Mothers who have got a previous baby with a neurotube disease. She does not need lifelong folic acid. You need to improve her folic acid for a period of 8 months, top it up with 5 milligrams, and then reduce to 0.4. But only a certain group of mothers, mothers who are obese, mothers who have got diabetes, mothers who are on anti-folate medications such as sulfasalazine or carbamazepine need 5 milligrams of folic acid. Not every pregnant mother needs 5 milligrams of folic acid. There are some concerns with regards to high doses of folic acids and fetal outcomes. But ladies and gentlemen, we don't live in the era of folic acid anymore. There's been a significant investment with regards to pre-conception supplements. And now we have numerous options, even far better than folic acid. Include vitamin D, include iodine, include vitamin B, and you can easily find pre-conception multivitamins which are tailor-made for all mothers. But be cautious of vitamin A. Please ensure that when a mother takes multivitamins, it does not have doses of higher than 3,300 international units of vitamin A. We spoke about vaccines, ladies and gentlemen. What vaccine is important? The measles, mumps, rubella. Ask whether she had a prior exposure of chickenpox. If she said yes, she does not need to be vaccinated. If she says she's unsure, check for varicella IgG. But she said she never had the varicella infection before. Talk to her about the vaccine. The COVID-19 vaccination is recommended in the UK, in the Singapore, but unfortunately, we do not have the vaccine in our shores. Other essential pre-conception vaccines are hepatitis B, HPV, influenza, and also rubella. Although the incidence of rubella is extremely low in Malaysia, mothers who have advanced age, advanced weight, it's good to screen for rubella IgG. During pregnancy, there are 3 essential vaccines. It is going to be influenza, it's going to be Tdap, the pertussis vaccination, and as early as August, we're going to have the RSV vaccine in Malaysia that's going to be given to all pregnant mothers. But pre-conception, these are the vaccines. I spoke about paternal health. ladies and gentlemen. For many years, we thought that the health of the mother, the age of the mother is important, but we should stop writing advanced maternal age. That is not the right thing to do, because the age of the father, the health of the father, the weight of the father is also extremely important. That is known as the epigenetic integrity. If the father has got a medical disorder, if the father smokes, that's going to be associated with poor sperm quality, and that is going to cause an increased risk in preterm delivery, miscarriage, preeclampsia. So the age of the father is extremely important, like the age of the mother. And studies now show that the best time to father a child is the ages between 30 to 35. The father is an age of beyond 45, there's a high risk of having poor fetal outcomes, and paternal age is associated. So preconception care in the clinic, not just focusing on the woman, talk to the husband, talk to the men, prevent STDs, talk about healthy weight, talk about smoking. Vaping has got higher nicotine administration as compared to smoking, so vaping is also a big no. If the father takes the medications, it is important to review the medications, especially sodium valproate in men has got poor outcomes in the fetus. And you can follow the 2 sperm cycles. Example, if the father is taking sodium valproate, she should stop it for at least 2 months and then embark on a pregnancy. If the father is subfertile, look for a genetic cause. It's important to ensure that the father is healthy. It is also important to ensure that the father supports the mother and that is associated with good pregnancy outcomes. We spoke about preconception care, and let's talk about the first trimester. Ladies and gentlemen, if you take a look at the trends in maternal death, one alarming trend is the rise in the incidence of ectopic pregnancies in Malaysia, where every year we still have a significant amount of mothers who die from ectopic pregnancies. So in your primary care, if you've got a mother who comes with a urine pregnancy test which is positive, she's got pain or she's got bleeding, never assume it is a miscarriage. You have to confirm that the pregnancy is intrauterine. So think ectopic in any woman who's early pregnancy who presents with symptoms, especially she's got shoulder tip pain, she's got GI symptoms, she's got abdominal pain, refer her to early pregnancy assessment unit. The second leading cause of maternal death, ladies and gentlemen, is venous thromboembolism. Please never assume that nausea and vomiting and morning sickness and hyperemesis gravidarum is normal. Please stop checking ketones, looking for electrolyte imbalance, or looking for loss of weight. If a mother vomits, if she's not able to function, that requires treatment. In UK, 1 in 4 mothers die because of complications from hyperemesis gravidarum before they could actually see a specialist. So in the primary health care, in the first trimester, if you've got a mother who's vomiting, please don't just give her Viloxin, please don't give her Maxolon. Think of venous thromboembolism. Hyperemesis gravidarum can be disastrous to a mother's life. So the current understanding of hyperemesis gravidarum has changed in a big way. In the primary health care, you can use the puke score. You can just Google it up. It's a score to assess severity of function. If a mother says she's vomiting, she's not able to function, that means she's got hyperemesis gravidarum. Numerous medications are safe. Ondansetron is safe. Domperidone is safe. Cyclazine, prochlorperazine, prednisolone is safe. If she's not able to maintain her hydration, please don't give bolus of fluids. Please don't feed her based on her ketones. If she's not able to eat and drink, timely referral is going to save lives. And she also needs low molecular weight thromboprophylaxis because hyperemesis gravidarum is associated with significant maternal complications. And these are in the first trimester. Let's talk about medications, ladies and gentlemen. If you've got a pregnant mother who's taking an essential medication, example warfarin, example azathioprine, example sulfasalazine, please don't ask her to stop the medication straight away. Please don't write a referral letter and ask her to go and see the obstetrician straight away. I think having a personal phone consult is extremely important. I'd like to introduce you all to BUMS website. You just need to Google BUMS best used in medicines in pregnancy. It's an evidence-based website that will be able to tell you if this medication is safe, is there a better alternative, or do you need to change medication? So the next time you're seeing a pregnant mother who's taking an important medication, don't stop. Don't ask her to go and see an obstetrician a few weeks away. Don't check the FDA. Don't call the pharmacist. Use evidence-based approach. If unsure, pick the phone, speak to a maternal medicine expert who will be able to guide you. But ladies and gentlemen, almost all medications, be it tacrolimus, be it cyclosporin, be it azathioprine, be it biologics, are all safe in the pregnancy, are all safe to be taken among mothers who breastfeed. There are only very few medications that are contraindicated, have an evidence-based approach. Even chemotherapy in pregnancy is safe. Once pregnant, I think everyone is well aware about the fetal assessment. But I believe, ladies and gentlemen, our approach to the pregnancy has been too fetal-centric. Please remember, ultrasound is important, but ultrasound may be able to save a baby's life. It's not going to save a mother's life. How many ultrasounds does a pregnant mother need? 4. In the first contact, please ensure it is intrauterine. You'll be saving a significant amount of lives. Then, in the first trimester, ideally 12 to 14 weeks, you can do a nuchal translucency scan. And people now talk about first trimester structural assessment. And then a detailed anatomical scan at 18 to 20 weeks. And finally, a growth scan at 28 to 30 weeks to make sure that the baby is not growth restricted and some anomalies evolve later. But ladies and gentlemen, what can you do in primary care? Think about the mother, assess her holistically. You can send some investigations. Ferritin. 30% of mothers will have a normal hemoglobin count but will still be iron deficiency. Send a ferritin. The incidence of diabetes in Malaysia is up to 27%. Exclude diabetes. Thyroid diseases, especially subclinical hypothyroidism, is more common among women. Screen for thyroid diseases. Check a BMI, check a blood pressure, look for a cardiac and renal costs. Think of syphilis, think of tuberculosis, think of malignancies, screen for GDM. You can do all this in the primary healthcare level. We can complement and support current mothers despite they are achieving and going to the private and public side of care. If you think you've got a mother who's high risk, refer the mother to the maternal fetal medicine specialist, not at 18 to 20 weeks, but as soon as possible. The sooner you refer, the better the outcomes. And think of aspirin, 150 milligrams of aspirin starting at 12 weeks. You're going to reduce the incidence of preterm preeclampsia significantly. There are a lot of medications that can be used to save lives. Ladies and gentlemen, based on the UK report, significant amount of mothers who died also had cancer. And the most common cancer among pregnant mothers, to your surprise, it is not breast cancer, but it's actually GI cancers. So the next time you see a pregnant mother who's got a PR bleed, please do not assume it is hemorrhoids. The next time a pregnant mother says she's got thrombosis, the next time a pregnant mother says she's got shortness of breath, think of a cardiac cause, think of cancer. If you see a lump, if you see a swelling, it is okay to biopsy, it is okay to image, it is okay to refer, because a significant cause, in fact, a rising cause of maternal death, up to 21% of mothers who died in the UK died because of a cancer. The investigation, the approach, and the treatment is extremely important. It is the same like a non-pregnant mother. And it's important to make sure that we treat all pregnant mothers the same like a non-pregnant mother. So think of GI cancers. If the mother has got an altered bowel habit, the mother's got a PR bleed, please never assume that this is hemorrhoids. Never assume this is normal. Investigate for a cause. This important slide is going to highlight a gist of a talk. We spoke about preconception care. Let's take a look at timing of mothers who died in Malaysia in the last 35 years. 1/3 of mothers died antenatally, 6% died intrapartum, 6% died early pregnancy because of ectopic and hyperemesis. But 55%, 1 in 2 mothers who died in Malaysia, died after childbirth. And ladies and gentlemen, that brings to the concept of the fourth trimester. Once again, an important phase that I think primary health caregivers can do a significant change and save more lives. So we have shifted the focus on pregnancy from preconception to now the fourth trimester. What happens in the fourth trimester, ladies and gentlemen? There's an important association between hypertensive disorders and cardiovascular health later on. Cardiomyopathy does not happen at birth. It is even more prevalent up to 6 months after childbirth. So your job does not end at childbirth. The risk to the mother has just increased soon after childbirth. The incidence of suicide is up to 16% after childbirth. If a pregnant mother was to die, the death is usually more violent and traumatic. VTEs increase after childbirth, infections is more common, and now we also know that complications that happen in pregnancy does not end in pregnancy may have long-term health implications, especially weight gain during pregnancy, especially GDM. So the fourth trimester is an extremely important phase in the mother's life. If we are to save lives, this is going to be the trimester that we should be focusing on. So what are the long-term implications of preeclampsia, ladies and gentlemen? If the mother has got preeclampsia during childbirth, 2/3 of mothers who had preeclampsia will die from cardiovascular diseases later on in life. If the mother has got preeclampsia, although you have saved the baby, you have delivered her safely, she's got a twofold higher risk of having heart disease. She's got a twofold higher risk of having stroke. She's got a fourfold risk of having high blood pressure. And I think this is what we should be looking at in the primary healthcare weeks to months after childbirth. Ladies and gentlemen, if the mother has got preeclampsia, she's got a higher risk of having ischemic heart disease before the age of 50, heart failure, aortic stenosis, and mitral regurgitation before the age of 50, 10 years after childbirth. This important study followed up all the mothers for a period of 35 years and looked into whether there is an association between preeclampsia and stroke. The answer is yes. If you think heart disease is more common among men, that is not true. Heart disease is more common among women, especially women who had preeclampsia. If you had preeclampsia, the chances of having an acute myocardial infarction is high 10 years after childbirth before the age of 50. And similarly, if you had preeclampsia, the incidence of having an ischemic stroke is high 10 years after childbirth before the age of 50. So women at a higher risk, women get stroke at an earlier age before men. There is an association between preeclampsia and cardiovascular disease. So how can we modify mothers in the fourth trimester? It is no longer TCA 6 weeks. It's no longer to see her for a pap smear. Ladies and gentlemen, the mother should be seen soon after delivery. Her blood pressure should be monitored for the first 10 days of delivery. On day 10, when you have the infant check, risk score her VTE, some mothers need extended thromboprophylaxis up to 3 weeks to 6 weeks. At third week, think of infection. Ensure that she's got no puerperal sepsis, screen for depression and anxiety. If she's got mood swings, even that last beyond 14 days, that is no longer blues. Blues usually only happens on day 3 to day 5. If it's past 14 days, that is postpartum depression. The first contact in a doctor after childbirth should be within 21 days, not 6 weeks, not 6 months. And that should be an ongoing assessment, and that should continue towards inter-pregnancy care. And this is the recommendation in the fourth trimester. All I believe the primary health caregivers can now own the fourth trimester and take responsibility. So ladies and gentlemen, I spoke about the implications of pregnancy and long-term health. Now we know that what happens in pregnancy does not end in pregnancy. And the fourth trimester is an important phase to intervene, to speak about diet, to speak about exercise, to speak about home blood pressure monitoring, and even to start aspirin and statins. And these mothers need to be followed up for life in the primary health care. At one time, they need to have a physician's assessment, but I believe the primary healthcare is going to make a significant difference, especially in mothers who have got hypertensive diseases, mothers who have got GDM, and mothers who have got preeclampsia. They need to be followed on for life after childbirth. So what is my recommendation, ladies and gentlemen? First, you have seen in obstetrician. Then we need to work together with the midwives and trained nurses and counselors. I think we need to work together with the primary care physicians and the family medicine specialists. We need to see the dietitians, and some mothers, we need to see the physicians, the cardiologists, depending on the risk. After delivery, please don't say TCA 6 months. I think the care does not end at childbirth. It has to be a continuum. It has to be holistic. And that is where we need to work as a team. And mothers who develop complications during childbirth should be referred back to the primary health care with a documented plan of what happened during pregnancy, so that the primary healthcare physicians, like the 113 of y'all here, can be empowered to make a significant change and to save more mothers' life. Ladies and gentlemen, then comes the concept of inter-pregnancy care. It is not just preconception, not just antenatal, not just postpartum, but not just fourth trimester. Every woman in the reproductive age group will either be before, during, after, or in between childbirths. So how can you take care of women inter-pregnancy care? Mothers who develop GDM, there's a 50% chance of developing diabetes in 5 years. So screen for diabetes annually, HbA1c. Mothers who had preeclampsia have got higher risk of cardiovascular diseases, statins, aspirin, diet, blood pressure monitoring. Mothers who gain weight during pregnancy. Ladies and gentlemen, it is no longer evidence-based to ask pregnant mothers to gain 10 to 12 kilos. That is not evidence-based medicine, because pregnant mothers who gain 10 to 12 kilos retain 30% of the weight. They do not return back to their normal weight. And all you need to do is to have 2 children. A mother will be obese somewhere in midlife. So every mother in the postnatal state, talk to her about weight management and weight optimization. And a continuous follow-up of diabetes, hypertension, cardiovascular diseases. The pregnant mother develops intrahepatic cholestasis. She's got a higher risk of developing gallstones and liver diseases. Women in the reproductive age group have got a higher incidence of developing connective tissue diseases and autoimmune diseases. Some mothers who have got pregnancy losses, mothers who are A&E positive, mothers who have got babies who develop heart block, they themselves may not have the disease, but the disease may flare and progress later on. They need surveillance later on. This, I think, can be done in the primary healthcare. Mothers who have got syphilis, HIV, tuberculosis, they also need monitoring. Mothers who develop thrombophilia, venous thromboembolism, has got a higher risk of having chronic thromboembolic pulmonary hypertension. They also need to be followed up for life. And of course, mothers who develop cancer, who recovered from cancer, also needs monitoring. And finally, mental health. So ladies and gentlemen, the work does not end. It is a continuum. The care for the woman is complex, but it has to be holistic. And finally, I would like to introduce the concept of transgenerational health. Ladies and gentlemen, there are significant factors that happens antenatally in the first 2 years of childbirth that's going to determine what and how healthy the baby is going to be. The mother is obese. The mother gains significant weight. If the mother smokes, if the mother has got a GDM, there's going to be a significant genetic programming and epigenetic changes, includes the father. If the mother has got a cesarean section, if the mother's baby is macrosomic or growth restricted, if the mother does not breastfeed, if the mother is exposed to antibiotics, there's going to be a significant change in the gut microbiome. Yeah. And if the mother overfeeds the baby for the first 2 years, the mother does not exercise, all this is going to cause transgenerational link. And the baby who's going to be born to these mothers later on is going to develop obesity and metabolic diseases, something that I think we should also focus in primary healthcare. So, ladies and gentlemen, how can we make a difference? I'm going to summarize my entire talk in this slide. I think any woman in the reproductive age discuss reproductive health, discuss preconception health for the woman and also for the man. Supplements think beyond folic acid, not 5 milligrams, but we have evolved past folic acid. There are numerous good multivitamins outside there that you can actually advocate to a woman. What happens to the mother antenatally, intrapartum, and the first 2 years of life is going to affect her fetus. Talk about healthy pregnancy, healthy preconception that's going to affect the next generation. If you've got a high risk mother who's obese, who have got medical disorders, who's age above 40, refer to the right expert. The maternal medicine specialist is going to make a difference in saving mother's life. The care should be holistic. I think it should not just be private, not just be public, but we should work synergistically to complement each other because we have got our strengths, resources, and time differently. Think about the fourth trimester. What happens during pregnancy does not end at childbirth. The risk to the mother has just started. More mothers die after childbirth than before childbirth. And think about inter-pregnancy care. It is a concept that every single pregnant mother will be until after she has completed a family. With that, ladies and gentlemen, this is the complex puzzle that's going to save mother's life. But the mantra for the day is treat pregnant mothers the same as a non-pregnant mother. It is complex, but as long as you put the mother in the center of your care, you would have made a significant difference. I'm going to share with y'all some free resources which is easily available on YouTube. You just need to Google Malaysian Obstetric Medicine Society. Anything and everything about high-risk pregnancy, from preconception health to paternal health to diabetes to thyroid to cardiovascular diseases is there. Free, and you can use these resources if needed, apart from using BUM's website. I'm going to end with a quote, ladies and gentlemen. The great Professor Mahmoud Fatala, who unfortunately died last year, made a strong statement and said, women are not dying of diseases that we cannot treat. They're dying because societies have yet to decide that the lives are worth saving. I'm sure the 113 of you all can appreciate the importance of elevating our care, the importance of working together, and I'm sure we'll be able to make a change. With that, thank you so much for your attention, and I'll be more than happy to take any questions. Thank you for listening, ladies and gentlemen.
Right. Thank you so much for that very comprehensive and in Malaysian style cepat dan tepat. I mean, the breadth of it itself is you have taken them from pre-pregnancy right through to the fourth trimester with all that data. Ladies and gentlemen, I don't think it's saying it lightly when I refer to Dr. Muniz here as an educationist, raising all our awareness with regards to maternal health. So thank you once again to all of y'all for showing that appreciation. The funny thing about Zoom is live, we can see that appreciation. Let's say we take this recording and put it into YouTube. We cannot see all those appreciation. That said, hopefully Zoom takes note of that. Anyway, cutting to the chase, there's one question. Muniz, you have done it very comprehensive. They have been flooded with information, and I think they have understood it perfectly. Can herbal cough syrup be given to pregnant women? Thank you, would be the question.
So the easy answer is yes. Never deny a pregnant mother an important medication that's going to treat her or make her better. I think when you talk about medications, always ask yourself, it is the difference between the benefit and the risk. The baby and the mother is protected in ways beyond imagination. For the person who asked an important question, I think you can use BUM's website. Just Google herbal remedies. Will come up with a list of medications that are not recommended, medications that are safe. But the easy answer is do not talk just about the risk, talk about the benefit and the risk. Since we are talking about medications, very few are contraindicated. I'm going to talk about antibiotics, Dr. Sivabala, if you allow me to.
Please.
Augmentin is not recommended. There is an association with fetal NEC. Tetracycline is not recommended. Erythromycin in the first trimester has got some concerns, but most other antibiotics are safe. But I think the gist is, if not sure, check evidence-based website. Not sure, it's okay to call and consult, but please do not tell her this is not safe and deny the mother just because she's pregnant.
Thank you for that. You alluded to NEC. For those varied here, of course, medical school did tell us necrotizing enterocolitis, especially in preterm babies. And in my enthusiasm to introduce Dr. Muniz just now, for those of y'all who don't know me, I'm Dr. Sivabala Selvaratnam. I practice in Hospital Ipoh Raja Permaisuri Bainun. Dr. Muniz was running the fetal medicine services in HKL until he decided that he could do more at the Pantai Hospital as a one-stop center for pregnant mothers, and he's moved on there. The next question, Dr. Muniz, is very informative talk from Dr. Bhavani. Can we start calcium early, as early as first trimester?
Excellent. Thank you so much for asking. That's an important question. The benefit of calcium is that there is an association that it prevents preeclampsia. The doses of calcium is at least 500 milligrams to 1000 milligrams. Studies have looked into who needs calcium. So any mother with a low calcium intake needs calcium supplements. So what type of calcium? Calcium carbonate has got a better absorption than calcium lactate. So if you are going to use and supplement, pregnant mothers use calcium. Now, when is the best time? There's a study looking into early and late intake of calcium. The study showed that if you start calcium after 20 weeks of pregnancy, is just as effective as starting it early. The problem with starting it early is that in the first trimester, the pregnant mother may have nausea, vomiting, reflux. Calcium is going to make her worse, is going to make her sick. So yes, supplement calcium the right time, the right dose, not too much after 20 weeks. You'll be preventing preeclampsia significantly.
Having shared that nugget on preeclampsia, Dr. Muniz, something that, when we deal with house officers, junior doctors in the whom you have trained numerous in HKL as well. But one of my favorite questions is, do you know how many? I asked the junior doctor, do you know how many women die of preeclampsia worldwide every year? And of course, they're like, why would I need to know that? Only if you understand the impact and gravity that 50,000 women die because of preeclampsia, then our index of suspicion would be adequate to make the timely referral, which you have alluded to during your talk, Dr. Muniz. And as I mentioned earlier in your introduction, you have already authored that book on preeclampsia as well. So you have an authority on preeclampsia right here. A question that comes to my mind, Dr. Muniz, when I introduced you as the president of the Obstetrics and Gynae Society, a rather hot seat, given that, women's health, you're championing that, and you have already completed 10 months in office as the president of OGSM. About 2 more months to go before the next annual general meeting and the scientific conference. Could you share what were your key moments during this past 10 months as OGSM president, looking after and advocating women's health?
Thank you, Dr. Sivabala. Very important, very difficult question. I think in obstetrics, the lifespan is only 10 months. And that is why God gave conception 10 months. So it's time to deliver, time to induce, and time to move on. Rather than speaking what I've achieved, I can perhaps share what I would love to aspire. I would find it extremely important and gratifying if societies like us, the ONG Society of Malaysia, the primary healthcare can work together in unity and we can actually elevate care to greater standards. That is something that I aspire. The job is not done. And I believe webinars like this and having important leaders like you in the women's health is going to make a significant difference. I think the care towards women is lifelong. But I believe primary healthcare doctors, the doctors, 115 out of them there, that are eagerly awaiting at 9 p.m., spending their precious evening listening to this, will make a change. I hope we can think of maternal health. The moment we elevate, think of maternal health, the society and the nation health is actually taken care of by itself. That is my aspiration, Dr. Sivabala. I may not answer your question, but that is what I hope to achieve in the next few months.
I loved it the way you tied in to the 10 months gestation or, that pregnancy and how your time in office. I think Dr. Muniz, you should also share with the audience how you have managed to bring the World Congress to Malaysia next year. I think that's a landmark in itself. A few words from you on how you have, yeah.
So I'd like to invite all of y'all to the RCOG World Congress that is going to happen in Kuala Lumpur. The announcements will be made next year. I believe we often speak about quality of healthcare, but only when we compare ourselves at international stage can we learn and can we elevate our care. So my advice to every single doctor outside there, it is important that we network, we share, and that's one of the most important reasons of how we have proved that Malaysia has got good quality of healthcare. We can actually deliver quality, high standards of confidence, and that is going to happen in Kuala Lumpur next year. How this happened? Thank you for the passionate, dedicated doctors in this country who continue to work together. And when is this happening? I can't make any announcement yet, Dr. Sivabala, but I can promise to you that it's happening in Kuala Lumpur next year.
We will keep our social media antennas wide open. Dr. Bawani has put up another question. Dr. Muniz, I would like to clarify, as we know, augmentin can cause NEC, but I realize some hospitals prescribe to mom in first and second trimesters, especially lower respiratory infection. Any comments on that?
Wonderful question. I think medicine is complex, and I think some doctors often prescribe something without having a proper discussion. In this time and era, we should practice evidence-based medicine, especially when you have got numerous options. So there are safer alternatives that has got no fetal concern, and that should be the first line. If we think there are no other better, safer options, and we think that is the one and only medication, that should be in discussion with the obstetrician, that should be in discussion with the patient, telling her the benefit, the risk, and the cons. And I believe the patient should be involved in that decision making. So, yes, obstetrics is complex, but if we make that effort to check, to discuss, I think we'll be able to improve and elevate care in a big way.
Hey, once again, thank you for that. Any final words in 1 hour and 5 minutes? We've still got 115, eager participants. You have packed it, jam-packed, jam-packed session with all that information right through, pre-pregnancy till the 4th trimester. Thank you so much, Dr. Muniz. We wish you all the best in your endeavors as the OGSM president, as well as the World Congress that you have successfully brought to Malaysia. Any final takeaways for our participants? I think you have summed it up very nicely. And again, the irony of this, we talk about women's health and everyone thinks, where are the lady doctors? And two male obstetricians are putting, starting the Women's Health Committee. But as we can see from the participants as well, patient care knows no gender, whether it's women's health, men's health. The best surgeons are women and the best obstetricians may be male doctors. I think it just cuts across. At the end of the day, we are here for patient-centered care, patient-centric care. As obstetricians, we just thought that women's health needed a committee, and that's how Dr. Muniz and I came together back in 2022 and started the committee. And looking at the tremendous support we are getting from our regular webinar monthly, episode 5 in May. Thank you for all the support. Thank you, Dr. Muniz. Wait, yes. Yeah, as expected, we've got a nice doctor here who said, may I get the recording, please? As I couldn't join at sharp 8 p.m. We understand on call in Taiping Hospital, which is where I started my housemanship. Thank you, Dr. David Darshani, for joining in. Recording would definitely be there. We will try to get it sorted as soon as we can, depending on the IT team. But we plan to put this all on our YouTube channels. And then, of course, because of the tremendous support, we would email the link. So I know some of the MMA members have stated that they are overwhelmed with the amount of email coming through. Not to worry, we'll tag it appropriately. Thank you for your support or something like that with gratitude, so that you are opening that email, looking at the link, and if you feel it's beneficial to your practice, click on it. And as they say in many YouTube channels, if you like what you see here and you'd like to see more, click right here to see more, like, subscribe, and support. Dr. Muniz, final words?
I think medicine should be holistic. What has eventually started as a holistic care, now it become too subspecialized. So my one piece of advice to all doctors there, I think we should own our patients, own the woman and the mother. Every mother and every woman only desires to have a healthy pregnancy and to be a mother at one stage. It's not about the obstetrician's work, it's not about the cardiologist's work. It is our work and our responsibility. If we can think about how we can holistically, physically, emotionally, and cover the entire spectrum, I believe that alone will make a huge difference in how we care for women's health. And Dr. Sivabala, thank you so much for doing a wonderful work. I'm so happy that the committee has evolved in a big way. And I'm so happy that we have got eager, enthusiastic doctors talking about women's health on a Wednesday evening at 9 o'clock.
Thank you. And good night, everyone. We'll see you with episode 6 next month. Thank you so much. Stay safe, stay healthy. Thank you. Good night.